So I think we'll head to our next speaker, who is Stephen himself. I've known Stephen for a very long time, actually. We're both in Edinburgh as medical students together, and he's done a lot of work overseas, and actually he set up and actually everything about from the whole day's talk is really many of them are his works, and he's been a great supporter of medical students and junior doctors, sending them to the Gambia, etc. So and then every so often he'll go off for a few weeks, and we're not quite sure where he goes, and so he's going to share one of his trips away, which is to Samoa. So all yours.
Thanks very much, Yincent. Can you see my slides? The usual question. I'm doing this from my iPad. Is that okay? Yeah.
Looks good.
Okay, great. So I am talking to you about one particular example of UKEMT's work, namely the outbreak response to Samoa just about a year ago now, to help deal with the kind of fairly unprecedented measles outbreak they had there around about this time. I thought it was interesting to talk about it. Certainly, it was interesting to reflect on it, preparing this talk about how, there were so many parallels between what happened in Samoa and then what was to happen just a few weeks later with the COVID-19 pandemic. And in many ways, the measles outbreak was a sort of microcosm of what was to come, with many of the same kind of problems and issues. And even with regard to vaccination, perhaps a kind of forewarning of some of the problems that we may have to come as we move towards hopefully an effective vaccine. Anyway, right, so this was December of last year, a huge outbreak, and I joined David, our last speaker, as part of the UKEMT team that went out there. I was the clinical lead for the doctors, and David was the nursing lead. I hope you can indulge me just for a few minutes, though, because it's kind of an interesting question, at least for me anyway, to reflect on how it was that I ended up, 6,000 miles away on a kind of tropical island in a hospital there, dealing with children with severe measles for 3 weeks, when my usual day job is obviously working in the Great North Children's in Newcastle. So, like many people on this call, I developed an interest not just in paediatrics but in global health as a medical student. In my case in Edinburgh in the late 90s, and then decided I was going to pursue that once I'd kind of got sufficient experience to be able to kind of bring some added value into that. So after I completed my general professional training in Edinburgh, I moved on to the Liverpool School of Tropical Medicine and did a master's degree there, and then followed my supervisor on to the University of Amsterdam to start a part-time PhD at the university there. And whilst writing that up, I then got a job with the MRC unit in the Gambia. We've heard Anna and Daisy talk about their experience there just early on this morning. And I joined the International Nutrition Group of the London School to carry out a large randomized controlled trial looking at peri-conceptional micronutrient supplementation in women and the effect that it had on kind of fetal and neonatal growth. After 3 years in the field, I was back in Newcastle. In fact, I arrived in Newcastle for the first time, actually, to continue my paediatric training. And when that was concluded in 2019, I specialised in infectious diseases and immunology. I moved on to a consultant post, initially at Northumbria Trust, just across the way there from Newcastle. But I was really looking for a way to continue my overseas interests in terms of research, ideally, but also in terms of clinical work. And so when the Ebola outbreak took hold in West Africa in 2015, I and many others signed up as an NHS volunteer and was deployed through UK Med to Save the Children in Kerry Town to help look after kids on the Ebola treatment centre there for a few weeks in the early part of 2015. And I enjoyed that work very much. And on the back of it, I applied to join the UKEMT just after it was verified by the WHO in 2017. And then found myself deployed to Cox's Bazar in Bangladesh in 2018 to help work on the diphtheria outbreak that was ripping through the camps there among the Rohingya who'd been newly displaced from Myanmar. Why do I do it? What use is it? Well, David's already touched on this in response to my last question, but essentially it's a tremendous clinical experience. This kind of work means that I get to see conditions which I really wouldn't see at home. Obviously, Ebola would be the most obvious example, but diphtheria, extremely rare, and even measles, actually, is very uncommon, severe measles anyway, in the UK. So great clinical experiences. You get particular hands-on response in experience in dealing with outbreaks, and then some great training opportunities to develop leadership skills, to learn how to deal with the media, and building resilience, working in constrained, challenging environments, which working in the NHS sometimes I feel like I'm drawing upon on a daily basis. And of course, it's extremely rewarding. I've met some fantastic people, sometimes in obscure places, but more often than not in airport lounges between flights to some far-flung places. And so it came to be that I was on call for the EMT in November and December of last year, and watched with interest as the measles epidemic took hold there at the tail end of last year. So Samoa, for those of you who don't know, is in the South Pacific. It's a few thousand miles northeast of Australia, and is composed of 2 main islands and a small number of tiny islands, and a population of about 200,000 people. It's thought that the measles virus was introduced into Samoa during a wider regional outbreak that was kind of erupting across the South Pacific region around about the early parts of 2019. And the first case is thought to have arrived in Samoa from Auckland on one of the 8,000 flights a year that goes between those two countries, and arrived and began to infect people in late August, early September. The first confirmed cases were not confirmed until the end of September, because samples had to be transported to laboratories in Australia for testing. And then a week or so later, the first very severe cases started to emerge, and tragically, the first death, in this case, a 14-month-old boy at the main teaching hospital on the island. A week later, the government declared a measles epidemic, and a day later declared a state of national emergency, in which, among other things, they closed the schools. They ordered that children under the age of 17 were not allowed to attend public gatherings of any sort, and made MMR vaccination mandatory in the kind of the early part of December going into January. And the reasons for that, and actually the reasons for the epidemic, are illustrated quite nicely, I think, in that graph in the bottom right of my slide, which shows that the uptake of MMR vaccine in Samoa had been pretty poor for most of the last 20 years. It peaked up towards the level where you would need to achieve herd immunity in kind of 2013, 2014, where kind of approaching 95% of children were getting at least one dose of the MMR vaccine, and kind of a slightly lower proportion getting the 2-dose regimen. But thereafter, the uptake started to fall off. The reasons for this are manifold. Part of it reflects changing population demographics and people moving from traditional communities with very hierarchical lines of authority, in which vaccination was expected in rural areas, in towards the big towns and cities where those kind of structures, those hierarchies no longer existed. And at the same time, the emergence of a very powerful anti-vaxxer social media campaign led by some high-profile kind of local celebrities, sports celebrities, and media personalities. And so by kind of 2018, we were getting down towards 30% uptake of the first dose of MMR. And then there was a tragedy when 2 children died following the inappropriate reconstitution of the MMR powder with what turned out to be an anaesthetic drug rather than the standard saline or water for dilution. And tragically, 2 children died, and that led the government to pause the entire vaccination schedule for about 10 months while they investigated what had happened. And so it never really recovered. And certainly by the time the first person arrived from New Zealand with measles, we had an entire cohort of children who were almost entirely unprotected against the virus. So I'm watching all of this erupt and conscious that I'm on call. And then, of course, at the tail end of November, this came through on my phone. So UKEMT utilizes a system of alerts through email and through mobile phone and phone calls and text messages to let you know that you're being stood up for deployment. On the advice of one of my registrars a few years ago, I perhaps stupidly attached the Thunderbird's ringtone to these messages when they come up, which gives you quite a shock when you're sitting in a ward round meeting and suddenly your phone starts to play Thunderbirds and telling you to get ready to deploy to the muster station. Of course, there's never a convenient time for these things. And at the end of December or the end of November that year, at home, my wife was about to start a new job. We were in the run up to Christmas and we had various activities and things planned with the kids. And not least, clinically, I was on call for the ID immunology service on the wards, multiple clinics to cover, all of which had to be frantically swapped or covered by my fantastic colleagues in the paediatric ID immunology service, who stepped up to allow me to be able to take up this opportunity. And luckily, the lead-in time was a few days rather than 24 hours, which gave us a bit more time to kind of sort all those things out. And I was able to go. So the next thing is a train journey down to very unglamorous Salford, which for reasons that I don't fully understand, but has been chosen as the muster station for deployments for the EMT. David might be able to explain why exactly it's in Salford. I suspect it's because it's quite close to Manchester, where UK Med is based at the university, and also, of course, close to Manchester Airport, from where you can get to pretty much anywhere else in the world. So the team made its way down to Salford for its pre-departure briefing, where we were given a quick overview of Samoa, its history, its culture, its kind of healthcare setup, the kind of healthcare needs that the island has already had, and a kind of update on where we were in terms of the number of cases of measles that were being diagnosed at the time we were about to fly out. So at that time, we were shy of 2,000 cases in total, but the number of cases that were coming through every day was rising exponentially. And at the point that we departed, they were seeing about 150 new cases every day. And very sadly, 22 people already lost their lives, almost all of them children under the age of 5. So here we are at Manchester Airport with all our kit. So there was the medical team lead, who Lizzie Marmont, who basically was in charge of the whole operation and looked after us all, made sure the logistics and everything were taken care of. We had 3 paediatric doctors and 1 anaesthetist, 8 nurses who were a mixture of emergency care nurses and children's nurses, and 1 respiratory physiotherapist who flew out to us a little bit later. You'll see there we've actually got very little kit. And that was because we were to be embedded within the existing healthcare infrastructure on the island. And we're going to work very closely with our sister EMT, OSMAT, the Australian medical assistance team, who are already in place on the island, a much bigger team. And we're already kind of hard at work fortifying and supplementing the care that could be provided by the doctors and nurses of the Samoan Health Service. So it takes a long time to get to Samoa, about 46 hours, in fact. And what are you going to do in that time but start to read frantically around measles? That might seem quite a thing for an infectious diseases paediatrician to admit to. But actually, thinking back, I think I've probably seen maybe half a dozen, perhaps 10 cases of measles in my career before I went to Samoa, within the UK, that is. And maybe one of those cases might have kind of ticked the box for a severe measles case. And the reason for that, again, is illustrated really in that slide, in the graph on the left-hand side of the slide, which just shows that as MMR or measles vaccine coverage has increased over the years, the number of cases that we see in the UK, the notifications, has really just fallen off precipitously. And now, barring a few outbreaks, regional outbreaks that we all hear about from time to time, we see very little measles in our day-to-day practice. So, so over the next 46 hours, I read everything I could find, from the Green Book to the WHO Hospital Care for Children Handbook to the Médecins Sans Frontières How to Manage a Measles Epidemic in 200 pages pamphlet, so that when I arrived, my head was spinning with facts and figures about measles. In short, it's, as we all know, is a type of virus. It causes an acute febrile illness characterized by very high fever of 40 degrees or more, a widespread mobiliform rash, and various respiratory symptoms. Humans are the only host. It's incredibly infectious. This fabled R number that we're also familiar with from COVID, for measles lies somewhere between 12 and 20, depending on the study that you read and the outbreak that you're looking at. So it's highly infectious. It's spread by respiratory secretions and in fomites, and it has a geographical seasonality. So in temperate regions, we tend to see clusters of cases in the late winter, early spring, whereas in the tropics, it tends to be in the dry season. And then superimposed on these seasonal cases, you get bigger epidemics from time to time, which tend to mirror vaccine uptake. The rash, as we all know, looks like this, except the problem is that most of the pictures of the rash that you'll see in books or even on the internet tend to be on white skin. And sometimes on darker skin, it's not always quite so clear what you're dealing with. And the rash, of course, can look like many other things. By the time we got into Samoa, effectively, case definition was being used for diagnosis. So there was no attempt really to confirm diagnoses anymore. It's just the number of the cases. And any kid who presented with a rash that looked anything like this, who had fever and one or more respiratory symptoms, was diagnosed as a case. Of course, measles can cause lots of complications, including cavitatory or cavitating pneumonia, can cause encephalitis and ADEM type reactions. And the treatment for it is largely conservative. It's fluids, antibiotics for superadded infections, and vitamin A, high-dose vitamin A for severe cases. And that's because there's a very strong association between suboptimal vitamin A status and disease severity. And in Samoa, although there was no evidence of acute vitamin A deficiency on the islands, studies about 10 years previously had suggested that a large number of people were consuming less than the recommended daily amount of vitamin A in their diet. So that was something we were aware of as we got into the field. So we arrived in Samoa on the 30th of November to join the Australian and New Zealand emergency medical teams who were already on site. The Aussies had built a 6-bedded high dependency unit to augment the PICU facilities already set up within the hospital. And we're busy building a second 20-bedded ward for children with measles as overspill from the main hospital, a attended ward that we, as the UKEMT, would be responsible for running. And by then, the number of cases were rising to about 200 per day. We were up at nearly 4,000 cases. And in those few days since we had our briefing, the number of deaths had over doubled, and there was now 53 deaths, again, almost all of them under children, very young children. So this is where we were based. It's the Tupoa Tamasisi Meawele Hospital, which is quite hard to say, or TTMH, on Apia, which is the main island, the main town on the second biggest island in the archipelago. It's known as the National Referral Hospital. It's a tertiary centre in terms of the facilities it can provide for radiology, microbiology, and general surgery. But in fact, most of what we would normally think of as tertiary cases would be referred to New Zealand by a bilateral agreement and be looked after over there and then flown back home once the treatment has been completed. It was only 140 beds at the outset of this outbreak, of which there was a single paediatric ward with 30 beds on it and 2 designated PICU beds in the general intensive care unit. By the time we got there, the hospital was operating at 200% bed occupancy and 80% of the admissions were children. So a complete reversal of their usual caseload and a huge overstretching of the very limited resources that they had in place. To give you an example of that, there was just 2 consultant paediatricians working, a few trainees, and then about 30 GPs who had been kind of seconded from private practice on the islands to come and work within the hospital. One of the things we had to do very quickly in the first couple of days was to kind of integrate ourselves into what was a very complex multi-agency working environment. The picture on the bottom right there just gives you some idea of the number of teams that were in play over the time that the UKEMT was deployed, coming and going at different times, bringing different resources and specialities and skills with them. And that all had to be integrated by the Samoan Ministry of Health and by OSMAT, who were taking a leading role in the international response. The picture in the top right there just, again, gives you an idea of various personalities from these organisations all milling about on the morning briefing every day for the daily updates. Every available bit of grass around the hospital seemed to have a tent from one NGO or government organisation plonked on it to provide extra working space for all of these individuals. And then each day we had to update the kind of the bed boards, really, to give us a snapshot view of how many cases we had within the hospital, what level of acuity they had, what beds were still available there in other hospitals in the area, and so on. And so this was, we had to master this and kind of find our place within all of this very quickly within the first 24, 48 hours, which is a hell of a challenge. Another huge challenge was the communications aspect. I've never before found myself wishing for an old-fashioned bleep or a deck phone. Instead, most of our communication took place over WhatsApp or an equivalent app called Viber. And the two screenshots you can see from my phone, they just show the number of different groups that we had operating at any given time with different sets of doctors or different specialty teams. There was one for radiology, there was at least two for micro and infectious diseases, and then there were the various social groups for the teams, and trying to navigate your way through all of the endless groups and the alarms and pings and notifications that were going off constantly through the day was also quite a challenge. And in amongst other, you can see one there called Code Blue, I think, which was the resource WhatsApp group that you had to text or call if you had a child who was arresting, of which at one point we were getting 4 or 5 every day. And so they were in heavy use. Of course, our role really was in case management. The children who were admitted were all, by definition, severely unwell with measles. On the one hand, we would see kids who couldn't eat or drink because their mouths were full of ulcers, those ulcers extending back into the pharynx and proximal airway, causing nasty croup and upper airway obstruction, children going into stridor constantly, needing big doses of steroids, and then no sooner had the steroids wore off and they were going back into upper airway obstruction again. Terrible cavitating pneumonias and pleural empyemas, chest drains galore, kids with pneumothoraces, having only ever put in 2 chest drains as a registrar under control conditions, finding myself supervising, in inverted commas, local doctors putting chest drains in multiple children every day was quite a challenge. But we were really lucky to have mobile radiology units provided by Osmat. Is the guy here going round, Tom, with his portable X-ray machine. And then the other slide shows the retrieval trolley that was kind of whisked around the hospital, bringing children on portable Optiflow, would you believe, to different areas of the hospital and retrieving them when they had arrested or were peri-arrest to bring them to the high dependency units and so on. So lots and lots of children on oxygen, lots of children on supported breathing with Optiflow or with kind of high flow oxygen of various sorts, and all being looked after according to a guideline which was already in place before we arrived, which stipulated which empiric antibiotics to use, when to send patients to various wards depending on their level of acuity, and so on. Meanwhile, in parallel, the public health community vaccination campaign was in full flow. We weren't involved with this directly, but we could see it's in operation all around us. And certainly by the end of our deployment, we would begin to see the benefits of it. So, as I say, the government made MMR vaccination compulsory and was sending round mobile vaccination teams the length and breadth of the country. Families were told that if they had any children between 6 months and 19 years of age living on the compound who hadn't been vaccinated, then they were to tie or hang a red cloth outside of their property, and the vaccination team would then stop, vaccinate the kids, and then move on to the next house. It was working seamlessly by the time that we were there, and in fact, within about 6 weeks, 90% of the population had been vaccinated, but it wasn't without its challenges. So this is Edwin Tamasisi, who was a very prominent business leader on the islands and a very vocal anti-vaxxer and critic of the government and international response to the outbreak, accusing vaccinators of killing their own people and advocating instead various remedies for measles based on high-dose vitamin C, vitamin A, and sometimes water provided by traditional healers. Eventually, he was arrested and charged with a public order offence, and I believe was jailed for 2 years in relation to that. But the anti-vax campaign has continued, and it just kind of bears thinking about as we move into a potential vaccine for COVID, about how we will get wide uptake of that vaccine to ensure this kind of mythical herd immunity is achieved. The other thing which was fairly new to me was working with the media. So because of the nature of this outbreak and the fact that it was obviously children that were involved, there was a lot of national and international media interest. Now, I'd done a little bit of media work before through UKEMT and UKEMT, and I've had a little bit of training. But as clinical lead on this response, I found myself being interviewed by The Telegraph, by The Mirror, a very brief interview on the Today programme one morning, and asked to record some stuff for Look North, the local BBC news service in this part of the world, which is something which I find very difficult, and I find myself getting quite nervous about. But probably a good experience to get used to kind of standing up and trying to keep messages very simple and powerful to have the maximum impact on audiences back home, particularly at a time when the NHS is under a lot of pressure, and suddenly, you've got 13 members of the NHS, some of them quite senior, being deployed to a country thousands of miles away to help with another infectious disease outbreak. Towards the end of deployment, I was lucky enough to work quite closely with local World Health Organization and public health organizations to help to think through some of the post-measles outbreak planning that was going to be required in terms of looking after children with complications or after effects of the virus. And it was very gratifying to see all of that work formalized in a report, which was submitted to the Samoan government and the Prime Minister just after we got back in early January. And in fact, I met the Prime Minister just before I left, and found myself really kind of surreally chatting to him about rugby, about which I really know very little. But he was a great rugby lover and had been to Newcastle some years before and has watched the Falcons play. Anyhow, it was great to kind of think about those kind of things and to be part of that kind of planning. And then suddenly, before we just basically kind of settled in, and it seemed it was time for us to go back home, we handed over our care to the second EMT team, photographed here below, which had a slightly different composition to ours. There were more physios, there were fewer paediatric nurses, and the doctors. There were 2 senior paediatric trainees and 1 ED consultant who was the clinical lead. So it had a different flavour to it, a different feel to it, and actually their workload was also very different because by the time they arrived, the number of new cases was falling quite quickly, and they were able to get to work augmenting or trying to help the hospital catch up with some of its kind of pre-measles care, setting up outpatient clinics and so on. And there was also an epidemiologist to help the local health statisticians plough through some of the data and help them plan their services going forward. The picture on the bottom left there just shows the full OSMAT and UKEMT Team 1 teams together just before we flew home. And then the picture on the right there is just taken from our analysis and activity summary, which was put together when we got back, showing that we probably looked after around about 520 inpatients during the course of the whole month of the deployment, different levels of acuity, and over a time when by then about 5,700 cases had been diagnosed and 82 deaths. So the end of the response really, in summary, showed what a kind of multinational, multi-agency response it was. We had 18 emergency medical teams deployed at one stage or another over the course of the outbreak. The government managed to vaccinate 95% of its population, and kind of found a home and managed to integrate over 550 EMT personnel in the space of about 2 months, which is quite incredible. The last case was diagnosed on the 12th of January 2020. By that time, about 3% of the entire population had been infected, it was thought. with an incidence or an infection rate of about 285 cases for every 10,000 people. 1,860 of those cases had been admitted to hospital, and there had been 83 deaths, which, when you kind of think of it in terms of proportions, that would be 25 in 10,000 or 250 in 100,000, really huge figures. It was thought that about 1 in every 150 infants, children under 1, died in Samoa from measles. So it really was an incredible and horrific outbreak that just kind of tore through the country, and then it disappeared again once vaccination got underway. Interestingly now, the Samoan government are kind of holding its breath about what's going to happen with COVID. They've locked down fully, completely, and they've had no cases so far. But there's some concern that measles, being an immunoparetic virus, will leave children particularly susceptible to this virus in a way that they're not susceptible elsewhere in the world for the next year or two, because we know that immune systems take a long time to recover from measles, and there's a degree of immune deficiency. The relative risk of invasive bacterial infection, for example, is about 3 if you've had measles, and that risk extends for at least 12 months. But at the same time, measles vaccination is known to have broad immunoprotective effects against other infections as well, for reasons that are still not completely understood. And so it's not clear how both of these things will offset one another. Absolutely. So that's it. I'm very happy to take any questions. This is just some of the team with one of our long stay patients who basically worked the full gamut from outpatients through the wards to intensive care, back to the ward, back to intensive care again. Was in with us for about a month and a half in total, or not quite that, but with upper airway obstruction, chest infections, and a degree of encephalopathy, but eventually made a full recovery and went home, for which we were all extremely grateful. And I think I've overran slightly, so that's me.
Great, thank you, Steve. That was very good and very comprehensive, and it's an amazing story. I think Ben was looking through things, but he's not here. Yeah, so yes, any quick questions, Ben?
Yeah, a few questions, some interesting ones. So what decisions and difficulties were there in terms of admitting non-measles cases, paediatric patients, to the hospital, given the risk of cross-infection with other paediatric measles patients? And then, I suppose, on the back of that, similar to what we had with COVID-19, were parents and patients more reluctant to come to hospital because of their perceived risk of catching measles in hospital?
So great question. So at the outset of the response, the hospital had developed 2 kind of parallel pathways into the hospital, acute pathways into the hospital, a measles and a non-measles pathway. But actually, by the time that we arrived, the number of non-measles cases being admitted was fractional. And almost all the cases coming in were with acute measles. Everybody else was not being turned away as such, but people were going to extraordinary lengths not to admit patients and to manage them in the community where possible. Because the case definition for measles was so broad, and because most children admitted to hospital come in with febrile illness, and the rash and some respiratory symptoms, I have no doubt that we did admit non-measles cases. We tried very hard to confirm contact history where we could and confirm vaccination status. In cases where children hadn't been vaccinated before they came in, and the contact history was vague, shall we say, we would give rapid vaccination on the ward as soon as they arrived. The reason being that by the time we got to that kind of conclusion, they'd already been in the environment for 6 or 10 hours, and were likely, if they hadn't been infected on arrival, were probably infected by the time that we were seeing them. But we knew that the immune reaction to vaccine strain measles is a lot quicker than the response to wild type measles. And so by doing that, we sort of offset some of the more severe cases that we might have otherwise seen. The problem was that we caused a lot of febrile reactions by doing that, and then we had to deal with febrile convulsions and all the rest of it. But anyway, yeah.
Another interesting question from Donald, who's worked previously during a pandemic in Papua New Guinea. So in the late 90s, they saw clusters of subacute sclerosing panencephalitis, and I wondered if that's been considered for the Samoa group now.
So also a great question. We didn't see a lot of encephalitis, at least not insofar as that we were able to diagnose it. Nobody got EEGs and we couldn't do any cerebral imaging. But in terms of clinical presentations, we didn't see a lot of acute encephalitis in the hospital. Of course, we've no way of knowing what was happening in the community. But that the neurodevelopmental outcomes of children post-pandemic is definitely an area of concern which is being looked at the moment. The problem is that outlook response is being run by 2 consultant paediatricians for the entire country. It was supposed to be augmented by doctors from New Zealand, but to my knowledge, that hasn't happened in the way that it was hoped. Probably because of COVID, I imagine, has kind of impacted the plans to kind of send doctors over to look at these kids. So instead, parents are being educated to look out for signs of delayed developmental progress, nutritional problems, ongoing chestiness, all that kind of stuff. But it's definitely an area of concern and will be for potentially for years to come.
And about the particulars of say subacute encephalitis, perhaps in another 5, 10 years.
Yeah. So again, as you know, with SSPE, you won't see that probably for another 8 to 10 years. It's extremely rare. I think it's about 1 in every 10,000 cases. But that will mean, given the number of cases that we saw, that we might get 1 or 2 cases on the island. But the island's on, there was only kind of 6,000 cases, so it shouldn't be much more than that.
Great. Okay, I think we might have to draw this to a close now, but that's excellent, Steve. And I'm sure he'll be around at the end to talk to anyone who had any more questions.